there. Let's start. This is a very important paper from Singalaki and friends, and they are describing the anomalies in three parts, nearly always detectable, potentially detectable, and undetectable. The first part is very important. Anencephaly, allobar holoprosencephaly, encephalocele, ectopia cordis, exomphalos, gastroschisis, megacystis, amniotic band secans, and molar change. We should catch all of these anomalies in first trimester, and sometimes we can potentially detect these anomalies if we have a good machine, and if we have time, we can catch these anomalies. But unfortunately, this part is impossible to detect. So we should concentrate in the first part of the anomalies. The ISIOC guideline is very good, the updated guideline. It is very important checking for aneuploidy markers, syndromes, and fetal examination, and the fetal environment, placenta, amnion, and adnexial muscles. This is the minimum requirements. We should always check these parts. Here are the examples and the pictures. As you can see here, the CRL, the BPD and HC and abdominal chamber, long bones, the fetal profile, ductus venosus, tricuspid valve, and the uterine vessels of the mother. On the other hand, these are the detailed anatomical survey, and I don't read them one by one, but if you have time, and if you have a nice machine, and if you have the knowledge of checking them, you can check all these structures one by one, and they are very important for the mother and for the baby. Of course, how to measure NT is very important too. You can find this information from internet, but the most important part is the CRL should be between 45 and 84 millimeters, and we should take the exact mid-sagittal view, echogenic tip of the nose, rectangular shape of the palate anteriorly, translucent diencephalon, in other words, thalamus, in the center, and the nuchal membrane posteriorly. Minor deviations from the exact midline plane would cause non-visualization of the tip of the nose and visibility of the maxilla. Neutral position is very important. Fetal skin and amnion also very important. We can wait for the fetal jumping to distinguish between fetal skin and amnion. The widest part of the translucency must always be measured. Inner border is important. Some machines spontaneously and automatically taking the entry. And this picture is very important for me because you can check many structures and many organs in one plane. This is not an only NT plane. You can check also intracranial structures like thalamus, like midbrain, brainstem, IT, cisterna magna, and nuchal translucency, and forehead, and some face angles. And this is the nasal bone. This is the rectangular shape of maxilla. Here is the vomer bone. This is the chin. Here is the thorax and abdomen, especially for the gastroschisis and the omphalocele. This part is very important. Here is the diaphragm for the congenital diaphragma hernia, and bladder, checking for the megacystis, and fetal genitalia. Sometimes we can check it from the mid-sagittal plane. We will talk about the normal and the abnormal one by one. Abnormal nuchal translucency, if NT below the 95 centile, let's correlate with biomarkers and then check the baby again at 20 weeks. If the NT above 95 centile, invasive testing is an option. Also, you can consider NIPT for parents. And early anomaly scan at 16 weeks, very important. If the NT is more than 3 millimeters, directly invasive testing is a must, is an obligation for the family and for the baby. There are some NT values here. The euploid group, the median NT value is 2 millimeters. Trisomy 21, it is 3.5. Trisomy 13, 4 millimeters. And if it is very, very large, very, very thick, it is probably the Turner syndrome. Also, by the NT values and by the increased NT, Nuchal syndrome, congenital heart defects, congenital diaphragmatic hernia, omphalocele, skeletal dysplasia, parvovirus, and also some metabolic syndromes. You can check all of them in one plane. This is the nasal bone. It is very important. Here is the nasal bone. If it is unossified or poorly ossified, it is a good marker for the aneuploidies. And you can do all of these options one by one. Here is a retronasal triangle plane from the Chile, from the Sepulveda, very important one. You can check also cleft palate and you can check also the nasal bone in one plane. This is an example of absent nasal bone. Yes, this is an tricuspid regurgitation. It's very important. You can see here the red dot, and here is the pulse wave Doppler. It is also possible in euploid group, so we should be careful. Sometimes it is an aneuploid marker, but it is sometimes transient marker. So we should correlate them with other markers always. And checking the heart at 16 weeks again for the early echo and early target scan. And this is the abnormal ductus venosus. Here is the reverse A wave. It is an abnormal finding. It is also possible in euploid groups, and it is a very important marker for the cardiac anomalies. In late gestation, also it is an ominous sign for the fetal growth restriction, and we should deliver the baby as quick as possible if we find the reverse A wave. And this is the summary of my first part of my talk. If it is the NT is the more than 95 centile, NIPD or directly invasive testing. If it is more than 3 millimeters, invasive testing is important. Absent nasal bone, both options are possible. And tricuspid regurgitations and abnormal ductus venosus are together, if together, detailed cardiac examination and correlation with screening is important. Let's talk about one by one. I don't write the name of these anomalies because, like my LinkedIn profile, I wanna think and I wanna discuss about these anomalies. Of course, it is a easy one. As you can see, you cannot see the calvarium, cranium. So this is an acrania, exencephaly, and anencephaly sequence. There are many different shapes, and the frog face is a hallmark sign. there is no brain tissue sometimes over the orbits. So this is a little finding, and we should almost always catch these anomalies in first trimester between 11 and 14 weeks. Yes. Here is another example. This is an termination picture of acrania baby, unfortunately. As you can see here, there is no brain tissue above the orbits, and other parts of the body, for example, upper extremities, perfectly normal. The chin, the mouth, there is no cleft lip and palate. The nose is okay. And the ear. Ear is, this is just an 12 weeks fetus, but you can check the ears perfectly. So this is another example. Let's check the baby. As you can see here, there is a large and big defect at the occipital part of the cranium. This is an encephalocele. This is very important. Here is the screenshot from the first clip. So we should check also the kidneys and the hands of the baby because of the Meckel-Gruber syndrome and some ciliopathies. This is very important. Yes, this is an example of allobar holoprosencephaly, monoventricle with no falx, no butterfly sign, also mid-facial defects. You can see here the proboscis, the single eye, trisomy 13, and syndromes also 20 percentile. And here is an microphthalmy and hypothyroidism case. As you can see here, the eyes are, the orbits are touching each other. And here is a proboscis also. So it is easy to catch allobar holoprosencephaly, but sometimes there are some mild variants like lobar holoprosencephaly or semilobar holoprosencephaly. So we should be more careful to catch them. Here is a dry brain, open spinal dystrophism, and encephalocele. Because of the cerebrospinal fluid leakage, the choroid plexus are totally filled the ventricles. So this is an abnormal finding. The other one is an abnormal finding too, because the choroid plexus are too small and they are not filling the lateral ventricles. So this is an example of early ventriculomegaly, but don't forget, it is a bit problematic to say ventriculomegaly in first trimester. So we should be careful and we don't say every cases the ventriculomegaly. Here is another example, the brain intracranial translucency. As you can see here, three sign, thalamus, midbrain, intracranial translucency, and cisterna magna. If there is a open spinal dystrophism, all the brain structures are moving to the baby's foot. So there is no intracranial translucency, a large and thick brainstem, and then some change like crash sign, like changing the frontal angle of the baby. So this is also IT can be increased, like this example. These are the examples of cystic posterior fossa. So we should be careful about the differential diagnosis to Blake Posh kyst or Dandy Walker malformation, because Blake Posh kyst is a very benign variant, but the Dandy Walker is very bad for the baby. So check the baby again 3 or 4 weeks later. For the posterior downward displacement of brainstem, and we cannot see the IT, and this is an example of an open neural tube defect. Yes, and crash sign is very important. In normal conditions, there is an space between the aqueductus and the occipital bone. But if there is a open spinal dystrophism, the cerebral peduncles come and touch to the occipital bone. This is like a crashing car to the wall. So this is the crash sign, and you can see the dry brain here, and there is no IT and a thick brainstem. Here is a good example of the direct visualization of the defect. The gold standard is, of course, finding and checking the lesion in the spine. But on the other hand, these are especially the brainstem, occipital bone, and brainstem formula, and the crash sign is very important for the open spinal dystrophism. Here is a 3D picture of a poor baby. As you can see here, the lesion is in the spine. Yes, fetal phase is very important, and I love fetal phase, and I am always reading and searching anomalies about fetal phase. Microphthalmus, as you can see here in this video clip, this is an allobar holoprosencephaly case. Here are the orbits. As you can see here, they are very, very small, and they are touching each other. Let's stop this video here. Yeah, these are the orbits, and they are very small, and they are touching each other. A hypothyroidism case. Aphakia, if there is no lenses and there is no iris in the eyes, we call it like aphakia. And hypothyroidism. This is an almost always together with trisomy 13. So genetic consultation is very, very important. Yes, other parts of the fetal face. As you can see here, fetal face, lips, palate, and jaw. Here is the small mandible and micro retrograde gnathia case. In normal conditions, there is a gap between the two mandibular bones, but in this example, unfortunately, there is no gaps between the mandibles. So this is an ominous sign for many syndromes. So we should check always them. And also Pierre Robin sequence, trisomy 18 and 13, triploidy, and genetical syndromes are very important. And autocephaly is a very severe case, absence of the mandible and agnathia. I have seen only one time in my life, and it was a very bad finding. Here is from my LinkedIn profile, and here is from my computer, from my ultrasound. This one is the normal baby, the face, normal face of the baby. As you can see here, the eyes and the nasal bone. Here, there is a very marked distance between two eyes of the baby, and there is a hypertelorism between the two eyes, and you can see the fetal ears very easily. This is important because in some syndromes, like Treacher's Collins and some syndromes, the ears are very important. Also, sometimes baby has no ears. So checking the ears, I think it's an important part of the first trimester ultrasound. And this is a frontonasal dysplasia baby. We genetically confirm the diagnosis later in pregnancy. So this is a frontonasal dysplasia. Here is the nasal bone. It is different than the normal, and there is a hypertelorism. Yes, sometimes we cannot find answers of our questions. There are two specular projections here. and we don't know the answer. They are from the eyes or they are from the eyelids, a cataract case, a bone or eyes, part of the eyes. We don't know the answer, but I am following the case when the baby is getting bigger or when the baby is born. I will share the answer with my friends. Here is another interesting case. As you can see here, the one of the nostril is here and the other nostril is here. And there is a big gap between two nostrils. And also there is a big gap between the two eyes. So this is an amniotic band syndrome and the bifid nose. The amniotic band cut the baby's face in the middle part. So this is a termination picture of the poor baby. Yes, let's talk about thorax. Diaphragmatic hernia diagnosis is possible if the stomach is behind the heart. It is a very early sign. So we should check the baby and we should check the other parts of the baby. It is very important. This is the left-sided hernia. The right-sided hernia diagnosis is very challenging. Direct visualization of the diaphragmatic dome is very important. Here is a little skeletal dysplasia case. Here is the bell-shaped thorax and long bones length. You should check other parts of the baby, echogenicity of the calvarium. So this is an very little anomaly. So we terminate the pregnancy, unfortunately. Yes, this is an ectopia cordis case. As you can see here, the heart is beating, but it is beating outside of the chest. So here is the same baby's 3D video. And as you can see here with color Doppler, it is a very rare abnormality, but it is very easy to check it and diagnose it. The high omphalos cell is important, and the heart is beating outside the chest. Also, sometimes it is a part of an contrail pathology. The components are midline supraumbilical abdominal defect, defect of the lower sternum, defect in diaphragmatic pericardium, and the anterior diaphragm defect. And also, sometimes there are some intracardiac anomalies in this case. Here is the hypoplastic left heart in first trimester. As you can see here, in normal conditions, there are two blood flows in diastole. But unfortunately, let's watch again. There is only one flow. So the other part is not working. And this is an three-vessel and trachea view. As you can see here, very large pulmonary artery and very small. And also there is another clue. In normal conditions, the color of the vessels should be the same. But in this example, the aorta is red one, this is reverse flow. This is a very important for the diagnosis of the hypoplastic left heart. Here is the opposite, hypoplastic right heart. As you can see here, the left side is working and the blood flow is normal, but unfortunately, the other part of the heart is not working. So this is an example of the hypoplastic right heart. Single inflow. In common AV canal, this is very important for the trisomy 21. As you can see here, there is a large regurgitation in the middle of the heart, and there is a large defect in the middle of the heart, especially in the crux part of the heart. And here is an example of a trisomy 18. This is a polyvalvular dysplasia. The colors are changing quickly because the valves of the heart is not working, so the blood is flowing, go and back very quickly. So this is a polyvalvular dysplasia. We should think about trisomy 18. Yes, the aberrant subclavian. This is one of my favorite. It is hard to catch it, but it's a great. I feel happy when I catch an aberrant subclavian artery in first trimester. Sometimes it's a normal variant. If it is isolated, there is no need to worry. In normal population, in 1% of the people have this abnormality or this variant. But cardiac screening and confirmation at 16 weeks is very important. Here is another important abnormality. This is right-sided aortic arch, the U sign. The trachea is in the middle of the duct and the aorta. So it is very important to check for DiGeorge syndrome and other parts of the baby, for example, face, for example, extremities, and also, of course, thymus. Abdomen, it is an easier part because we can check the baby when we are taking the abdominal chamber. If we see a protrusion like this, it is a very important clue for the exomphalos and some trisomies, especially trisomy 18, and the back with Weidman. Here is the 3D picture of the same baby. And this is the gastroschisis. The bowels are floating in the amnion freely, and the aneuploidy risk is very low in gastroschisis. On the other hand, in exomphalos, the aneuploidy risk is very high, especially the small defects are very dangerous for the aneuploidies. And of course, kidneys are important. Sometimes it is hard to check kidneys in first trimester, but if we can study and work about them, we can check the kidneys very easily. And this is the lying down adrenal gland. This is a very important clue for the renal agenesis and pelvic kidney. We should be very careful because sometimes the kidneys can be next to the bladder. So we should check the baby's bladder and the other parts because of the pelvic kidney is a very common variant. And this is the megacystis. If it is between 7 and 15 millimeters, the chromosomal defects are very high. But on the other hand, if it is more than 15 millimeters, the obstructive uropathy probability is very high. But the normal diameter should be less than 7 millimeters. Yes, the cystic kidneys. I have talked about the Meckel-Gruber syndrome and cephalocell polydactyly, cystic kidneys. For example, here is a postaxial polydactyly. Here is very large kidneys. And this is another example. As you can see here, cystic and large kidneys. And encephalocell. And as you can see here, this is the postaxial polydactyly. This is a Meckel-Gruber syndrome, genetically confirmed. Here is the single umbilical artery. It's very important, but sometimes we should be careful because false positives in 5 percentile and re-examine the patient at 16 weeks for confirmation. Limbs are very important, especially this is a poor fetus with absent fetal limbs, Amelia. And this is fused lower lips. This is a Sirenomelia, mermaid fetus. And this is the Phocomelia, extremities attached directly to the torso. The transvaginal ultrasound is very important for these catching and checking these defects. Then, of course, this is a radial ray defect. It's very important, especially in trisomy 18. And as you can see here, the abnormal for arm bone, persistence flexion, and these are the associations of these anomaly: Holtoram, amniotic band, Cornelia de Lange, Fanconi anemia, and omphalocele radial ray complex. But the trisomy 18 is the most probable pathology. And these are the ectrodactyly, split hand, split foot malformation, and these are the amniotic band. Unfortunately, amputation of the digits, and these are the termination pictures of the poor baby. Polydactyly, preaxial and postaxial one. Here you can see the postaxial. If the extra digit covers the little finger, we call this postaxial. But the extra finger is near the thumb, we called it the preaxial polydactyly. If it is in the middle, we called it like central polydactyly, but it is a very rare one. Sometimes there is no bone inside the extra digit. This is the flash in Abin genetic consultation, and also it is important to check the family, checking the parents, because there is a familial condition. And these are the example of an lethal skeletal dysplasia. As you can see here, the thorax is very narrow, and abdomen is ballooning, and you can see the intracranial structures very easily, and because there is no classification at calvarium, and you cannot see also the vertebra. This is a good example of an lethal skeletal dysplasia. Micromelia, all the long bones are short femur, narrow thorax, and the mineralization defect, and sometimes both bones, especially in campomelic dysplasia, you can see some both humerus and both femurs. And also, when we are checking the fetus, environment is very important. Chorioamnionic separation, it is physiologic until the 16 weeks, but after the 16 weeks, it's a pathology. They should fuse by 16 weeks. And this is a limb body wall complex. As you can see here, this is a very little and severe abnormality. The baby cannot moving, and there is no umbilical cord. And here is the circumvallate placenta, the shelf connecting both ends of the placenta. Sometimes it can be together with the fetal growth restriction. And take-home message: the 11 and 14 scan is not only NT measurement. With advanced technology, it is possible to diagnose most of the anomalies in first trimester. And first of all, be patient for the ideal fetal position. Check the mother again and again. Use transvaginal ultrasound liberally if there is a suspicion. Enough magnification of the image is a game changer. Color Doppler using is very important for obese patients and first trimester cardiac screening. Good machine is important, but not everything. Use a detailed checklist and control the organs and systems step by step in an usual order from head to toe. Human embryology knowledge is very important for understanding mechanism of the fetal anomalies. It is important to take cine clips and save them for retrospective checking if you miss anything. And educate your eyes for the normal anatomy, pattern recognition, and save them in your brain. And when you have a suspicious case, call them back again. Update yourself always and follow the latest papers and guidelines. Finally, of course, you can miss anything. Don't demoralize yourself. Just think about your mistakes and don't repeat them if possible. And special thanks to my friend from India for valuable contributions. And this is my LinkedIn profile. I have more than 15,000 followers, and we discuss very interesting cases almost every day. So I'm waiting to my page and welcoming everybody for beautiful discussions. And thank you very much for your patient listening.
Thank you very much for your presentation. We
Hello.
are very grateful.
Thank you very much.
Yeah. So there are questions, but we'll take that at the end of the presentations.
Yes.
So we'll now be inviting Lasha Jones to present to us on her topic.
Okay, that was a wonderful presentation. Thank you. Thank you. I learned a lot. I learned a lot as much as I do, especially on your LinkedIn profile. So thank you for that impactful presentation. I'm going to share my screen. Let me pull it up here. Give me a second. I also want to thank you, Paul, for the invitation to be able to share with you all in your audience. I appreciate that. Let me make sure. Okay. Can everyone see my, well, it's loading. Can everyone see my screen okay now?
Yeah, we can see you.
All right. All right. Well, let's get started. So today I am going to be talking about a topic I feel that is often not talked about enough. And so we're going to go over some tips and tricks and techniques in how to diagnose or how to recognize the lung lesions. So we're going to discuss precision in prenatal imaging, and we're going to master the ultrasound diagnosis of CPAM lesions. Okay, let's get started. All right. So what are the difference between a CPAM lesion or a CCAM lesion? What are the differences? So starting with CPAM, which is also known as a congenital pulmonary airway malformation, it is the current preferred term used. It's described as a developmental abnormality of the fetal lung. So basically, the lung tissue is abnormal. It appears as a cystic or solid mass due to an overgrowth of the terminal bronchioles. And some of the lesions may contain a few fluid-filled cysts, gland-like structures, or dense solid tissue. Now, CCAM is the same. It's exactly the same as a CPAM lesion. CCAMs are also known as congenital cystic adenomatoid malformations. It's just an older term that some still used in practice. Now, with CCAM lesions, it highlights the cystic and glandular tissue patterns seen within the lung tissues. Both terms refer to the same condition. Okay. All right. Now, it affects approximately about 1 in 25 to 35,000 pregnancies. And typically, these lesions are picked up in your second trimester, not necessarily always at the 20-week scan. A lot of these may get picked up later on, even closer into the third trimester. So that's why I always find that it should be helpful that you still do a third trimester scan because things tend to appear later. Now, with these lesions, it usually involves one lobe of the lung, but it can occur in any lobe. Okay. All right. So once again, it is usually unilateral. Now you see the difference between the left lung and the right lung. And so with your left lung, you have your upper, your mid, your lower region. And on your right side, that's where you have the superior lobe, middle lobe, inferior lobe. I find the right side appears a little larger, as you see here in the diagram. Now, with these lesions, they can either appear macrocystic, so you'll have a large fluid-filled space, or they could appear microcystic. With these tiny cysts, we tend not to see those unless it's like under a microscope, so they're really, really small. It will cause the lungs to be enlarged, more hyperechoic, or appear as a hyperechoic mass. Now, with your mixed lesion, that's a combination of a cyst. You'll see like anechoic areas as well as some echogenic areas as well with the mixed lesions. All right. Now, why does it matter? Well, this is rare. Why are we concerned with this? You know, currently we have 3 cases within our practice of lung lesions that were picked up. Some were missed, but we did eventually find it in the third trimester. it's still an anomaly. It's still a risk that can happen. So it's really safe to say that we should be prepared when we find a lesion, what protocol to follow in order to document and diagnose. Okay. And also, it can compress the mediastinal structures. It can compress the heart. It can compress the trachea. So this is a very we really need to diagnose this prenatally to help, because of the potential risk that it can carry on throughout the pregnancy. Okay, so let's take a look further. Here it says, how can it be detected prenatally? What are some steps that we can follow in order to be able to detect this lung lesion? So right away, once again, I mentioned that it's most commonly identified during the second trimester, but don't be alarmed. It can be picked up in the third trimester as well. And it's going to appear as a bright echogenic mass. Some are bigger, some are smaller, so keep that in mind. And then they're going to have either a single cyst or multiple fluid-filled cystic areas. And some, depending on the size of the mass, it may shift the thorax or the heart to the side, the opposite side. And in some cases, it could cause an excess amount of amniotic fluid. Okay, let's go on. Now the difference, I have some demonstrations here of these cystic areas that we can see throughout the lung. Now with the macrocystic, these cysts will be greater than 2 centimeters. Not seen here, but you can see the difference. It's going to be a little bigger than what's shown in a demonstration. Now with the macrocystic lesions, these are most often corresponded to the Stalker type 1 and type 4 lesions. Okay. Now with your microcystic, those cysts are really, really small, often smaller than 5 millimeters. And so it's going to cause your lung tissue to appear hyperechoic, so super bright, super white. And this will often correspond to type 3 and the microcystic type 2 and 4. All right, so let's take a closer look at that. Now, type 0, that one is incompatible with life, unfortunately. And these aren't usually detected internatally. Okay. Now, the type 1 will present as a large cyst. So those cysts will range between 3 through 10 centimeters. That's known as macrocystic, and that's usually the most commonly one seen. Type 2, which is often associated with other anomalies, that's going to be cysts that we saw in the demonstration, less than about 2 centimeters. Okay. And then it may have some solid areas. Okay. Now, type 3 is those tiny cysts that's going to cause the lungs to be hyperechoic, appear solid as one echogenic mass. These are the ones that are going to displace the heart. Okay. And then type 4, unfortunately, is often associated with malignancy. The cyst size are often microcystic. Okay. And you may have some large cysts there as well. Okay. All right. So here's an example. Once again, we measured the cyst here. Within, notice the range here, 0.2 centimeters, 2 by 1. So it's still a smaller cyst. And then here is that echogenic lung lesion presented there. Okay. It's a pretty, I feel like the lung is pretty large. So that lesion is pretty large. So it caused a shift slightly of the heart in this demonstration. All right. So I'm a geek when it comes to embryology. I have to, the way my mind or my brain works is if there's an anomaly, I have to know why. I have to know what went wrong during the development process. So of course, it's only natural that I include the embryology behind the lung development. And so as you see here, the lungs develop in 5 stages, start in about 4 weeks. As I mentioned here, that's stage 1. There are some key events that happen in each stage here. So I'm going to just go through those, and you can follow along with the cycle that's seen here. So that first stage, this is very important because this is the formation of the lung bud, okay? And that's derived from the foregut. Your tracheas and the bronchi are formed during this particular stage, okay? And that's done pretty early. Now, after that, you're going to head on over to weeks 5 through 17. That's your pseudoglandular stage. And the key event that happens there is the branching of the airways down to the terminal bronchioles. Okay, now just following along the cycle. The next stage is stage 3. That's happening around our 20-week scan, so week 16 through 25. This is the formation of your respiratory bronchioles, and early vascularization is starting to happen. And then from there, we're getting into our third trimester, weeks 24 through 38. Your terminal sacs are forming, your start of your surfactant production. And then this was something that I had no knowledge of, but your lungs, or the fetus lungs, are still maturing and developing postnatally. So from late fetal to childhood, there's still some maturation process happening with the lungs, even after birth. So that was important, just to know the guidelines of where or how the lungs are developed and what went wrong during the timeline. So let's see what happened in the case of a CPAM. Where did it go wrong with a CPAM lesion? Now, with type 1 CPAM lesion, this is most commonly, they stated, and typically arise from abnormal branching between the primary and secondary bronchi. So this is during stage 2. Okay, remember stage 2 was right around weeks 5 through 17. So this process happened prior to your 20-week scans. Okay, all right. Now, just to take a step further, overall, the CPAM is thought to be disrupted early on. Here it mentioned that there's a disruption with the airway branches during weeks 5 through 6. Now, in cases where the lungs aren't there at all, that's simply a result from a complete failure of the bud to form. And then in cases where there is some aplasia with the lungs, then it occurs when the bud forms, but the lung parenchyma failed to develop. Okay. All right. Now, first and foremost, if you want to start picking up these lung lesions, you have to have your system and in place so you can be able to pick up these lung lesions because they can easily be missed. So I am going over a few techniques now on how to optimize your image quality in order to be able to pick up these lung lesions. So first and foremost, you want to start with a high frequency. Okay, this is going to allow for that adequate penetration. And that's commonly the 5 to 8 megahertz in your second trimester. Okay. Now, a lot of our systems automatically will adjust for the TGC and gain. I remember when I first started scanning, we had the toolbar, we had to adjust the TGC, but now we have a button that we can push. Usually my correct button will adjust the TGC for me. But just keep in mind that you want to adjust the TGC to brighten the posterior lung area because you can miss the lung lesion in that particular region. Ensure that there is a uniform grayscale across the entire thorax. And with your focal zones, this is really important. You want to place it at or just below the area of interest. In this particular case, it will be your lung mass. Okay. Now let's take a look at the depth and framing. It's really important because if you want to evaluate the entire thorax, you can't be too zoomed in, as you can see in the example. So zoom out your picture to include the lungs as well as the heart, okay? Now, some advanced tools, we have the tissue harmonic imaging as well as compound imaging and speckle reduction. Those are very helpful in just creating a great contrast there within your picture. So with tissue harmonics, it's going to improve your resolution. The compound imaging is going to reduce the artifact. You want to think of like the rib shadowing. So you want to reduce those artifacts that the rib shadows may cause. And then speckle reduction will give us a cleaner tissue plane, which you can see in the demonstration. All right, so let's go over the trend of how the lungs will appear from our first trimester to our second and third trimester. Right away, you can see these are all first trimester examples of the lung tissue. And so notice in the first trimester, the lung echogenicity appears low, okay, which you can see here. Now, later gestations, the echogenicity will increase progressively. But I do want to point out on your left side, this is a 10-week fetus. And then, of course, we see a 12-week and a 13-week. Even within the first trimester, you can see the echogenicity slightly increasing within the first trimester. So I did want to point that out. All right. Now, some of our modern imaging tools, such as our 3D, will really highlight the lungs. And so here's an example of 3D lung tissue seen with the surface feature as well as the easy volume. And so basically, it's just showing the echogenicity of the lungs, and they appear to be more echogenic than liver. And so I just wanted to highlight that you can use other tools to really show the lung tissue and how normal it can be. Now, if you don't have access to these tools, it's totally fine. A grayscale is often, look here, you can see things fine. And I do want to point out with the right side, how, remember we spoke earlier about it's larger than the left side. And you can clearly see that with the grayscale imaging. That's standard imaging. Now, if you want to take a step further with your grayscale, you can change your chroma map. And it's the same picture, it's just you're seeing it in a different plane, a different contrast. Different contrast here. So just another way. If you don't have access to the advanced tools, your grayscale works fine. All right. Now, with that interface that we spoke of the lung being slightly brighter or more echogenic than liver, I wanted to show that or highlight that with this picture here. Okay. So you have the lung tissue, you have the diaphragm, and then here's your liver. You can see the difference between the echogenicity, and you can see the difference with here, slightly echogenic bowel. They all had a different echoes. So I wanted to point that out, the difference here. Okay. That's going to become important when we talk about differential diagnosis with the hernias and so forth. So we'll talk about that here in a sec. All right, into the routine evaluation process of what to do and how to recognize these lung lesions. So first and foremost, assess the lungs for homogeneous echogenicity and symmetrical development. So you want to identify anatomical relationships between the spine, the ribs, the sternum, the clavicles, as well as the diaphragm. You want to confirm the heart position within the thoracic cavity, and you want to do this with these three standard views: the axial view, the sagittal view, and the coronal view. So we're going to take a look at all three and highlight some key advantages in each one. So starting with your transverse axial view of the fetal thorax, right away you can see this is considered to be the primary view to evaluate the lungs. It's especially my favorite because I feel like the rib shadows aren't really in view with this particular plane. They're behind the lungs, and so you don't have that artifact. You can see both lungs directly in contact with the heart, the mediastinum, and the ribs. And then with this particular view, you want to demonstrate or show that there's no fluid present within the pleural cavity. Okay, so this is the ideal view right away that I feel like you can really see all of these highlighted. Okay, now let's take a look at the sagittal view. Now the sagittal view includes, you want to include both your left and your right sides. It's very, very important to do that. But with this sagittal view, take a look here where you can really see that diaphragm clearly intact. And that's very important, especially as we were mentioning about the congenital hernias. Okay, so you want to demonstrate that hypoechoic line clearly separating the thorax from the abdomen. Okay. All right, and with the coronal view here, this is also highlighting the intact diaphragm, which we can see here. You can clearly show that it's intact. You're also showing the symmetry of the lungs, both left and right. Nice symmetry, the lung value distribution. See, this is another ideal position. A lot of these views, we're looking at other things. We're looking at stomach, diaphragm, bladder. We're not sometimes realizing that we're evaluating the lungs in those views as well. Okay. All right. Now, those potential risks that I was speaking of earlier, is usually these three here mentioned. The hydrops can develop, which is often ended in a poor prognosis. With hydrops, that's either with the pericardial infusion or extra fluid there around the heart, pleural effusion, skin edema, and ascites. Now, the mediastinal shift is due to that lung mass just pushing things over. It could cause a compression of the heart and lungs. This risk is for pulmonary hypoplasia. And then also, you have to check your amniotic fluid levels because you may see an excessive amount of amniotic fluid. So it's just all part of your diagnosing as well with the lung lesions. Okay. Now, you know, I find it helpful to have a protocol in place for any anomaly within your practice. And so with lung lesions, I feel like these steps mentioned in here will help in a consistent protocol in the case of when you spot a lung lesion. So just to briefly go over each step, starting with the first one, in the comprehensive evaluation strategy, you want to evaluate both lungs as well as the heart, the diaphragm, and those pleural spaces. And from there, if you so happen to suspect or see a lung lesion, you want to determine which lobe is affected. Is it the right? Is it the left? Is it upper or lower region? From there, the types that we went over, you want to identify which one that you're possibly seeing. Is it microcystic, microcystic, or is it a mixed appearance? Then, just depending on the size of the lung lesion, you want to look for a displacement of the heart or trachea. And then that will help kind of understand how significant is that mass effect. And then you can assess the cardiac function from there. Okay, so you want to evaluate for compression, chamber size. If there's fluid surrounding the heart, you want to measure that pericardial fluid as well as the fluid within the lung tissue if it's there. Now, I wouldn't look at the fluid just yet around the fetus. I'll first throw on my color Doppler. When you put on your color Doppler, you're checking to see if there is any blood flow connection to the lung lesion. Now, in cases where you may see a blood vessel from the aorta, then that will help you in that differential diagnosis that we will soon talk about in the sequestration. Okay, if you notice that. If there is no connection, then it's most likely your CPAM lung lesion. Okay, and from there, you will evaluate your amniotic fluid. Okay. All right. Now you see the lung lesion you want to measure. And so there is a ratio calculation to measure in cases of you see this relative lesion size, just to assess. And what is the purpose of this ratio is to determine the risk of hydrops forming. So it's very important in your management. And so this ratio consists of 0.52 by, and look here, we're in a transverse view, but we're measuring the length, and then from your sagittal, the width and the height. You're going to divide that to the head circumference, and you'll come up with a ratio. Now, normal ratio values is less than 1.6. If you have a ratio less than that, then lower risk of high drops. But I want to go over the potential risk of high drops. I want to break down, I have a chart here because it's especially important with management for your patients. Now, I've worked with several MFM doctors, and I found that everyone will do things differently. So it's not always the same. And so this is just a suggestion, I would say, that's one can follow. But of course, we all have our standards and protocols set in place. And so particularly, if you see a CVR value that's less than 1.2, I guess we can include the first two together. So 1.2 to 1.6. It's a low to moderate risk seen. No large cyst is present. And with these patients, we tend to monitor once a week or twice a week. And that varies. It depends on the gestational age and the initial CVR ratio. Okay. Now from there, if you notice, you have a low to moderate risk when it's right at 1.6 and there is a cyst present. And so typically we treat these patients as high risk and we're going to monitor more frequently. So these patients usually come 2 to 3 times weekly. And of course, if it's greater than 1.6, it's a higher risk of high drops happening. It really varies if there's a cyst present or not. And then from there, you're going to also monitor about 2 to 3 times a week and assess closely for high drops. All right, so let's look at some differential diagnosis. As I spoke earlier with the so with BPS, this simply is a non-functioning lung tissue that has a systemic arterial blood supply. And you can see there in the demonstration, it would still appear as a echogenic solid mass, which could be confusing. But what stands out is that blood vessel, okay? Now, this may coexist with a CPAM as a hybrid lesion, so I wanted to point that out. And another one that's often confused with CPAM is the congenital diaphragmatic hernia. And so with this particular one, the bowel loop or stomach is seen within the thorax. And the middle sinus shift, depending on the side that the hernia is on, you may observe where the diaphragm is separated here. You won't see necessarily your stomach, or you could. Just really depends on the severity of the hernia. A lot of times the stomach is visualized within the thorax, and poly is associated with this anomaly as well. All right, so let's look at them side by side. Here is a case of a diaphragmatic hernia that we currently have, and then it's side by side next to a CPAM. Okay, now right away, if you notice the differences, it's with the diaphragm. Clearly, we can see with our CPAM that the diaphragm is intact all the way across. Yes, we see the lung lesion there. We see the cystic areas. Everything's above the diaphragm. Okay, I don't want the cystic lesion should not be confused with stomach or so forth, especially when you see the diaphragm is intact. Now, in the case of the hernia, we had this, the abdominal organs were, the defect was on the left side. And so they were pushed up into the chest, shifting the chest over. I do have a clip where you can see the stomach adjacent to the heart. Okay, so the key distinction between BPS and CPAM is that the BPS is not going to be connected to the tracheal bronchial tree, and it is supplied by that abnormal systemic artery. Okay, CPAM will receive the blood flow from the pulmonary circulation. Okay, and then with the other two, the CDH is herniated abdominal organs, which is visible through that diaphragmatic defect. CPAM is just that intrathoracic mass, no diaphragm defect. Okay, now they may both show the mediastinal shift, but it's from different causes. Okay, so let's take a look at this one in particular. Okay, so this is a demonstration of a congenital diaphragmatic hernia. You can see where the heart is shifted off to the side. Here is the stomach, not to be confused with a cystic lesion. And the lung, that is actually the stomach adjacent to the chest. Okay, and so everything was just pushed up within that thoracic cavity through that diaphragmatic defect. When we did throw, you see here, you can see where you can see both of them side by side, and it's causing that heart to shift over. Okay, and let's take a look here. Next one. All right, and with this particular slide, my takeaway with recognizing lung lesions or any anomaly within the fetus before I take any pictures, and if anyone follow me on LinkedIn, you may have heard this before, but before I take any pictures, I first do a thorough sweep throughout the entire fetus. And so I want to actually start over so we can see from the beginning. This is a 30-second sweep, and I'm evaluating, let's start over, top of the head to orbits, palate. I'm scanning through. I see the diaphragm is intact. I see my stomach below the diaphragm. I saw bladder. We're assessing the abdominal wall. Now I'm within the chest cavity. Okay, I'm still sweeping. Now back into the chest cavity. I see my heart. I saw my lungs, my stomach, my diaphragm. I highly recommend, especially if you're scanning, before you start taking your pictures, just to start off with a sweep throughout the entire fetus. And just make it a habit to do this first before you start taking your pictures. And that way you can really get a full evaluation through this 30-second clip. Okay, and that is it, Paul. I am all done. I hope that everyone had a few takeaways from this topic that's often not talked about enough. Oh, I can't hear you.
Yeah, Nuchal, thank you very much. You really did
Absolutely.
great. We really appreciate you. And there is a whole lot of information you have dished out in this your presentation. I hope all of us will be able to catch up.
Thank you.
We are recording it so people will have opportunity to go through it over and over and be able to pick the informations contained in the presentation.
Absolutely.
So I've been trying to reach out to Islam, and he said he's having network issue. So that he's trying to make a final attempt with the IT department and see if he will be able to join in the presentation. Okay, so while waiting on him, we can move ahead with the question and answer. And if there is any contributions from Dr. Sama, Dr. Muslimat before the panel session, you are welcome to go ahead with your contribution. So I'll quickly go to the questions and answers, and everyone is actually free to contribute to the question and answer. So for Dr. Koskin's presentation, we have a question that said, which is more reliable at 11 to 13 weeks scan? Is it the prenasal thickness or nasal bone length for predicting aneuploid?
Hello?
Yeah, I can hear you.
The nasal bone is more reliable because the prenasal thickness is not a first trimester marker. It is a second trimester marker. So we don't use the perinasal thickness in first trimester. We just use nasal bone, NT, ductus venosus, and tricuspid regurgitation in first trimester as a marker.
Okay. Any other contribution? Okay. So the question also said, when nasal bone looks hypoplastic or absent, how to know if it is true Down syndrome marker or just ethnic variation?
Yes, it is a very good question. In normal conditions, if the nasal bone is absent and it is an isolated finding, we don't worrying about so much. Especially we can check the parents' bone and ethnic origin because of in Asian population, the nasal bones are normally smaller. So it is isolated. We can just check. We don't need to worrying about. Maybe we can do an IPT test if it is available in your clinic. Of course, if there are other abnormalities with the nasal bone, we should do the invasive testing.
Okay.
It's okay?
Thank you very much. Yeah. I don't know if we should go on with the questions. He also said how to differentiate normal physiological midline brain cysts with holoprosencephaly at 11 to 13 weeks scan.
Yes, it is an interesting question because there is no physiological midline brain cyst in first trimester. Maybe we can talk about common valley interposity. It is a normal physiological cystic structure in the middle of the brain. But on the other hand, holoprosencephaly is different. It is not like common valley interposity. It's a monoventricule. The ventricles are touching each other and the choroid plexus are also touching each other. And another clue in holoprosencephaly, mostly there are some facial abnormalities like proboscis or like cyclops or microphthalmia. So it is easy to differentiate the allobar holoprosencephaly from the midline brain anechoic structures.
All right, thank you very much. Okay, so to Lasha Jones, the question that was asked is that, is the presence of fetal echogenic kidney a predictor of possible polycystic kidney or MCKD? I think it's also to Koskun. Anyone
Yeah.
can read that, yeah.
Yes, it is about kidney. It's a good question also. If the kidneys are echogenic, in normal conditions in first trimester, the normal kidneys are also echogenic. But we can check and we can correlate the echogenicity of the liver and the bowel. They should be nearly the same in first trimester. But on the other hand, the autosomal recessive cystic kidneys are very large, and also abdominal chamber is large. It is bigger than the BPD and the other long bone measurements. So if it is isolated, we don't so much worrying about the echogenic kidneys in first trimester. But if there are some others problems, other anomalies, we should do invasive testing.
The next question they ask is the side of the single umbilical artery, left or right, important in predicting anomalies?
I wanted just to about this because I know on my LinkedIn profile, I often suggest that you do document left versus right. From the cases that I've seen, almost always, if the right sided is absent and the left is present with the umbilical artery, there are numerous anomalies. And I'm talking from the ones I've seen, more than one. It's usually associated with emphalocele, heart defect, maybe a club foot. Like there's usually two anomalies or more present in the case where the umbilical artery was absent on the right side. Have you seen that, Dr. Koskin, in your practice?
Yes,
Mm-hmm.
I can. Yes, I have seen in my practice. The
Mm-hmm.
question is the umbilical artery
Mm-hmm.
absent on the right side or left side.
Mm-hmm.
I think is there any there is no differentiation about pathology. It is not depending on the right side or the left side.
Mm-hmm.
But as I said before, there are some false positive diagnosis in first trimester because of the color Doppler settings. So
Mm-hmm.
it is better to check it again in 16 and 17 weeks.
Mm-hmm.
Okay. Dr. Sama, do you have any contribution on that? You are on mute.
Hello, everyone. Hello, my colleagues. Very informative presentation. Thank you for you all. Thank you, Mr. Paul, for inviting me for this session. Thank you, Dr. Koskan. Thank you, Dr. Lachelle, for these and informative, insightful presentations. We need to discuss about at first the first anomaly. Actually, this is very challenging to diagnose all these anomaly from the first trimester. But I want to discuss or ask, is there any limitation for the abortion in the first trimester regarding all these anomaly, or most of this need follow up after this, especially in the not CNS related anomaly. Okay, the CNS is settled. The termination is termination in over the world, but the other anomaly need follow up, or you take the decision by termination.
I think question is for me.
Yes, this is the first question for you.
In Turkey, we can terminate only the lethal abnormalities. For example, an upper extremity abnormality. We don't terminate them, and we continue the pregnancy. But as you can see, if it is lethal, for example, an anencephaly, a cranial complex, or like an very severe amniotic band syndrome, very large defects, we terminate the pregnancy. And in Turkey, we don't have any pregnancy week limit in our laws because we can terminate some microcephaly or some corpus callosum agenesis cases in later pregnancy. So it depends on the family's decision and, of course, the lethality of the problem.
Okay, because the limb abnormality diagnosis is very challenging, really, in the first trimester. So I don't know how to contribute this to the pregnancy. Is there any guideline regarding the follow-up?
Yes, of course, in ISIOC guideline, the upper and lower extremity is in the checklist list, but we don't count the fingers in normal conditions. But you should check the long bones, and if you have a slim patient and a good machine, you can easily check the upper and lower extremities. especially in the mid-sagittal view, and the retronasal triangle view is also possible. When you slide the probe up and down, you can check the both extremities very easily. Because the advantage of the first trimester, the baby's hands are open, but in advanced gestation, they are mostly closed. So it is hard to differentiate them. It is an arthrogryposis, or it is an central nervous system problem, or it is just an coincidental situation. So it is better and it is easier to check the extremities in first trimester, if it is possible.
Very informative, really. Thank you. Thank you. Regarding I want to discuss regarding the MDT team. The MDT team, because I face some problems in the connection between the multidisciplinary team in Egypt. So I want to discuss this in this session. Especially when you find or found any abnormality, how to counsel this to the patient, and how to discuss this with the other team. Can I share my screen, Mr.?
Yes, please go ahead.
Okay. From the lecture of the CCAM or CPAM, important to discuss with the patient the post-surgical management strategy. You must assess with the patient what's the lesion, or identify to the patient what's the lesion. Typically, if the lesion is large, symptomatic, will cause any symptoms to the patient or to the baby after birth, or it will be asymptomatic small lesion with the surgery in late. The surgery will do in the late childhood. And regarding the counsel, we have multiple consequences to do. The first thing in the counseling of the patient is to break down the finding into simple and non-technical language, and use visual aid, the image. You can illustrate simple illustration to the mother or the parents, and allow give them time to ask about the hazard and the outcome of the baby. This is regarding the cardiac anomaly. If there is a cardiac anomaly, important to counsel the patient as well as the team. Important to refer the patient to the tertiary hospital to avoid the emergency transfer postnatally, which may be risky or will be high risk to the fetus.
Okay.
And I want to discuss one case. It's my special case, because this case clearly identify if there is a good MDT team, or if there is any break in the team, or what will be the hazard. This baby was referred to me. The mother complaining of small cyst in the lung and the small cyst in the abdominal cavity. The cyst was misdiagnosed, and the obstetrician cannot define if the cyst is related to the GIT cyst or related to the lung and chest. By examining the fetus, there was a small cystic lesion here in the lung. There was very small defects in the diaphragm. Maybe this image, because the resolution of the image and the resolution of the machine is not that good, but I suspect that there was small defect in the diaphragm. By more examination, detailed examination, there was shifting of the cardiac to the opposite side. So this image or this case was very challenging, because it's in late trimester and we cannot do anything. cannot do any treatment option intrauterine because the intrauterine surgical intervention is very limited in Egypt. And I counsel the patient, and I will discuss later what is the step of counseling of the patient in any abnormality. But in this patient, there was good connection between me and the obstetrician. The obstetrician trust me when I told him there is a small bowel here in the thorax cavity. So I suspect there's a small diaphragmatic hernia. Because this bowel loop is clearly demarcated here, that's shifting from the abdominal cavity to the thoracic cavity. But the not good thing is that the pediatrician is with this misconnection, not trusting the radiologist too much. He was not connected to me. The connection was not direct between us. So there is no good connection between us. And after birth, he examined the baby. Was my report. The left hemithorax seen increased in volume and altered echogenicity. Deviated cardiac to the opposite side and distended bowel loop is noted. Suspected by the end is suspected small diaphragmatic hernia. Unfortunately, when the patient is born, the fetus was very good condition. So the pediatrician didn't call me, didn't ask, didn't investigate the baby, and tell the mother that the baby is very good. Okay, what happened that the baby underwent to circumcision? By crying and more crying, the diaphragmatic hernia increased in size, and this bad event happened. By X-ray, the baby cyanosed and went to the emergency department by large diaphragmatic hernia. This was the X-ray, and by the report of the ultrasound, immediately X-ray and immediately the emergency surgical procedure was done. So that's why I need to highlight the importance for the MDT team. Multidisciplinary team is very important. The connection between not only the radiologist and the obstetrician. You must inform also the pediatrician with your point of view, with your investigation needed, because this is very critical to the baby. The prenatal counseling framework has different steps. The first step, you must explain the condition to the mother or the parents. If the baby has congenital airway, if the baby has any other abnormality associated, use simple language and use visual aid if you can illustrate visually to the parents. Discuss the variability in the outcome. This is the second step. What is the outcome of this lesion? If it's a small lesion, will be shrink during pregnancy. If it is large lesion, need another surgical intervention or any other things. Explain the key prognostic factor. What affect the prognosis of this condition? The size, the type of lesion, if there is any associated hydrops, if there is any associated abnormality. And also outline the monitoring plan. We need to follow up this baby, this fetus, through what is the procedure, through serial ultrasound, if we need to do, for example, MRI, if there is any other monitoring plan, discuss this to the patient. Discuss the possible intervention. If there is any availability for prenatal scanning, a prenatal intervention, or the intervention after birth, either surgical removal of the mass or surgical intervention if there is any cardiac abnormality. And after birth also, if it is the surgery immediately or need after the baby stabilization. And what is the long-term prognosis? What this disease will affect on the long term, how it affects the baby in the long term. The survival after surgery, maybe if it is good condition, in the good prognosis, 90%, and maybe the remaining lung in case of surgical resection of CPAM lesions, maybe very good prognosis, the remaining lung grow and compensate, and if there is a risk of infection or there is a risk of malignancy, will be discussed with the patient. And the parent support, this is very important item, the psychological support to the parents. And also, finally, the multidisc reassure also reassure the parents, and the multidisciplinary team must involved in this reassurance to the patient. Thank you. Thank you.
Thank you very much.
You're welcome.
We
Thank
really
you.
appreciate your contribution. This came earlier than we wanted it to come.
Thank you.
So thank you very much. So we'll quickly move into the panel discussion because Islam is not able to make it to this webinar. So I will invite Dr. Muslimat to share with us, as a pediatric surgeon, her insight on the typical postnatal surgical management strategies for anomalies like the CCAM, and although the TGA was not presented today, but she can still share with us her insight on the postnatal surgical management strategies for CCAM. So,
thank you so much, Mr. Paul, and thank you, everybody. Thank you to all the presenters, Dr. Sama, Dr. Koskum, and Dr. Lachelle, for the very exciting and interesting presentation. I've definitely learned a lot from all your presentations. As a pediatric surgeons, particularly in this part of the world, most of our patients with congenital anomalies come mostly as postnatal patients, although occasionally we see them following prenatal diagnosis. But majority of the cases we see are actually cases related to the gastrointestinal tract and the urinary tract. Occasionally, when we see cases like the CPAM or conditions involving the airway, most of them, essentially what we do prenatally is to plan postnatal management, essentially in terms of referring to places where they will get optimal care, that is the tertiary institution, and then also planning the mode of delivery if there is a need for a cesarean section, depending on the condition of the fetus and the abnormality. When we see them postnatally, most times they get their primary management from the cardiovascular surgeons, most times cardiovascular and thoracic surgeons. But essentially, just as the earlier speakers have spoken, the treatment majorly is surgical. The timing is usually determined by the mode of presentation and the type of anomaly the patient has. Most times when patients present with, when they present in an unstable state, probably because of the size of the mass with the pressure effect, or because of features suggesting imminent eye drops or established eye drops, they may need immediate postnatal resection. While majority of them that present with smaller lesions that may even be asymptomatic would have the opportunity of further evaluation before they eventually get their definitive management. The experience with TGA, that's transposition of the great arteries, is not so robust in our practice, because majority of these patients, the extent of management that they can get within this country based on our own peculiarities. So majority of them end up getting referred to the tertiary centers, and even some outside the country, in order to get optimal care. And some of those that have been managed elsewhere with feedbacks, we have been able to have them do well post-operatively. I hope you can hear me. Looks like I'm offline now. Hello, can anybody hear me?
we can hear you, sorry.
Okay. Thank you. So majority of the few ones that we have seen that we have had to with feedback have done well, essentially. So that is it about the management. But the most cases that we see postnatally are cases like patients with antenatal hydronephrosis, either unilateral or bilateral, usually from posterior urethral valve, and then occasionally anterior abdominal wall defects, particularly gastroschisis, which we manage postnatally after planning the mode of delivery and the timing and the location of the delivery. Thank you.
Thank you very much, Dr. Simat. I'm trying to remove this, but I don't know. Okay, yeah. So thank you for your insights on the postnatal management for CPAM. So I would like to ask Lachelle Jones, as an advanced prenatal sonographer, can you share your experience on how prenatal imaging findings are communicated to parents and how this impacts their preparation for potential postnatal interventions? Because we here in Nigeria, as sonographers, we usually have this much restrictions in terms of communicating to patients based on your findings. So because you are not the doctor that is handling these patients, so you can be able to see an anomaly, but how you communicate to the patient about it matters too. So as a sonographer in your position, how do you handle this?
Yes. So same thing for here in the U.S. We as sonographers aren't allowed to give diagnosis, and so in cases where we see anomaly, we we're often going to the MFM doctor, discussing with him or her. And a lot of times, depending on the practice, the MFM doctor may have you come back into the room as they're discussing the findings with the patient. And they may even have you scan if they're not, all MFM doctors don't scan. For some that don't, they may have the sonographer scan and help point out what we're seeing. So then they can discuss the findings with the patient that way. But as a sonographer, even here in the US, we aren't allowed to give diagnosis or even speak with the patient on abnormal findings. So it's the same here as well. Mm-hmm.
Best advice you join. If there is need for you to be present during the discussion with the doctor, you should be able to be there.
Mm-hmm. Yep.
All right. So I don't know if we have any other contributions or suggestions before we call it a day. Although there are other questions that have been asked here, I should end this webinar by 8 p.m. on the dot, so we can have enough time to rest. I think there was a question on the aberrant right subclavian artery in the first trimester. If aberrant right subclavian artery is reliable, or does it appear only if after a certain gestational age? Any contribution on that?
Yes.
Cosco?
Yes, Lachelle is a professional about aberrant right subclavian artery. So I wanna listen her thoughts about ARSA.
Mm-hmm. ARSA, my dear friend ARSA. Like you said earlier, ARSAs are tricky. They're not every presentation of ARSA isn't the same, and so it could get missed. So just some tips, techniques. I would say because it's a lower velocity flow, so you want to change your color Doppler setting to accommodate for that. So if you have a high PRF scale, you're going to miss ARSAs almost always. You have to turn it down. You agree, right, Dr. Koska?
Yes, I agree with you. Yes, yes,
Mm-hmm.
yes. Absolutely.
Yes. Mm-hmm. The best scale would be lower than 20. So you'll be able to capture that. Now, once your scale is adjusted, it almost always is picked up in the first trimester. We are seeing these ARSAs pretty early, and if you suspect it, you're going to bring patient back at 16 weeks to confirm.
Oh.
Yeah, um, that's all I had to say.
Yes,
Um,
it is very important because the right PRF is very important
mhm,
because for the small vessels you should check the PRF and I think the position of the baby and some of the color Doppler physics is very important also because in some conditions it is impossible to see the ARSA as you said, but
mhm,
it is better to wait the baby turning right side or the left side. So it is very easier. It is more easier, and sometimes I check the patient and I miss the ARSA, but in her next visit, I found the ARSA in the same patient.
mhm,
So I said, "Wow, I miss it and I catch it." As you said, some of the ARSAs can be missing very easily because very
mhm.
small vessel and you should be careful.
Yes, I agree.
That is wonderful. Thank you very much. I will just take the last question before we call it a day. And the question is in first trimester and you noticed an echogenic bowels without any associated abnormalities, what would that suggest to you?
It is yes, it is possible sometimes seeing an echogenic bowel, and there are many reasons and many causes of the echogenic bowel. Especially the most of them is pregnancy bleeding in first trimester. If there is an abortus imminens and there is a risk of miscarriage, you can ask the patient, "Did you did you have any bleeding in first trimester?" And if the answer is yes, it is most probably the baby swallow the blood of the mother, and because of it, the fetal bowels are hyperechogenic. But on the other hand, of course, it is a it is a small marker of it is a mild marker of the also echogenic bowel Down syndrome. So you should check the other part of the baby very carefully. Lachelle, what do you think about echogenic bowel?
I agree. I agree. I would say 15 years ago, we would do an amniocentesis because of an echogenic bowel, but you don't hear that as often now. And so it's like a combination of markers seen where you will recommend an invasive test. But so yeah, I totally agree with you. It's similar to the echogenic focus that you'll see in the heart as well.
Yes.
We tend not
Yes.
to make such a big fuss, especially when it's isolated in those cases. So yeah, I agree.
All right. Thank you very much.
Mm-hmm.
We want to thank each and every one of you for your time and your dedication to this webinar. I'm really grateful to each and every one of you. And I don't want to say this, but I really want to one day look forward to seeing each and every one of you coming to Nigeria to help us with hands-on training.
Mm.
Why not? Maybe
This,
someday.
and
Okay.
we
Yeah.
hope that
We are
will
ready.
one day work out
Mm-hmm.
with the help of the foundation and